Hi, welcome to Glenohumeral Gurus, a podcast for clinicians with an interest in shoulder pathology. I'm your host, Margie Olds, and it's a pleasure for me to bring you these podcasts. The aim for the podcast is to deliver some clinically relevant content for you. I plan to interview people from all over the globe and talk to clinicians and researchers and anybody with an interest in shoulder pathology so that we can learn how to help these people better. So settle in and enjoy the podcast. Hey, it's my great pleasure to welcome Behnam Liaghat to today's podcast. Behnam, welcome. I'm so excited to hear about this work you've done. Welcome. It's really nice to have you.
Thank you so much, Margie. Thank you for having me.
So today I particularly wanted to talk around some of the research you've done in high load for hypermobile shoulders. But before we start, could you maybe tell us about your physio career so far, how you got to be in this space and what you're doing now? Tell us about you.
Sure thing, Margie. Well, my name is Behnam Liaghat. I was born in Iran and moved to Denmark in '92 with my family. And I'm a sports physio by background, educated in Denmark. And I took a master's degree in sports physiotherapy at the University of Bath in the UK.
Wow, I didn't know that.
No, so that was a nice switch from the Danish system going on with a sports physio masters from the UK, and really that really opened some opportunities in my career.
Yes.
So after finishing my thesis at University of Bath, I took a PhD degree at the University of Southern Denmark in the research unit for musculoskeletal function and physiotherapy, where I'm now employed as an assistant professor.
So tell us, this work you've done on high load and hypermobile, this is part of your PhD? That is this?
It is, yeah. So what happened during my master's project was that I got the opportunity to work with the world-renowned Danish hypermobility researcher called Dr. Birgit Juul Christensen. And I got the chance to somehow combine my interest for working with competitive athletes with doing research.
Yes.
And more specifically, we investigated potential risk factors for developing injuries in the swimmer's shoulder.
Okay.
And interestingly, we found that hypermobile swimmers without shoulder symptoms, they potentially display strength deficits in medial rotation, which they use for propulsion.
Yeah, okay.
And that the swimmers with generalized joint hypermobility actually developed muscular fatigue earlier than non-hypermobile swimmers. So that somehow sparked my interest in the area of hypermobility.
Do you think, so putting my clinical hat on, I'm thinking, so these patients that are hypermobile are using their muscles to both stabilize as well as produce force. What do you think? Why do you think they then developed fatigue earlier? What are your thoughts?
Well, based on some of the electromyographic analysis we did, we could see that the coordination of the muscle work around the shoulder joint was different.
Okay.
So, for example, they seem to have a lack of activity in the serratus anterior muscle, but use their rotator cuff muscles more to stabilize the shoulder.
Wow.
So that could indicate that they somehow have a discoordination in the muscle work around the shoulder joint.
Yes.
And maybe that's the reason they fatigued in some of the test measures we did.
Because of the way that they are recruiting their muscles differently.
That could definitely be some of the arguments.
Yeah. And so that is what sparked your interest in doing this high load hypermobile. That is where that came from, hey?
Basically, yeah. So it took me, after the master's project, it took me around 1.5 years to both like get prepared for the PhD project and to find the funding and the opportunity to get started. And after that, I started my PhD journey with Dr. Birgit Juul Christensen as my main supervisor. So that was a really nice switch from the master's project to
yeah,
the
to
PhD.
forming that relationship. And like we were saying just before, there's such a need in these athletes who need that high load and who are hypermobile. So it's such an interesting piece of work. And also doing the randomized control trial it's enormous piece of work you have done, isn't it?
Well, it is, and I'm grateful of the results we got, and that
Yes,
we were able to recruit 100 patients from Danish primary care, which
yes,
is quite a lot in a PhD, and we had a great success rate. So after the 4 months of intervention, we had like a retention rate of 93 patients out of 100.
yeah.
So that's
Wow.
quite nice.
Yes, that is
Um,
also nice. The thinking about the high load program, why did you think it would be appropriate? Because that's not what we've seen in other parts of the literature. Why tell us about high load, what that means, how clinicians could think about that in this population.
Sure. So current guidelines recommend low load exercise. That could be low load stability exercise, low load strengthening exercise
Mm,
for patients who have generalized joint hypermobility and shoulder symptoms or shoulder conditions. And due to uncertainty about the effectiveness of high load strengthening exercise and patient safety at the time of the study being initiated, we knew that high load strengthening exercises were seldom used.
yeah,
But what we can say is generally that the patients who have shoulder symptoms, they lack stability in their shoulder. They are weaker in the rotator cuff muscles. They are weaker in the scapular muscles.
mm,
And they have discoordination in the way the glenohumeral joint works during functional movements during sports and so on.
yes,
And we know also from interesting studies from Alziri and Shea Palmer et al. That in hypermobile people, we have using elastography, we have a less stiffness of the muscles, we have less stiffness of the tendon tissue.
yes,
So there is somehow there is a need of a better active stability of the joint.
yes,
And what we thought was, okay, we know from different shoulder populations that are not related to instability or high load, instability or hypermobility,
mm,
that it can be useful to use progressive high load strength training to
mm,
somehow build up that functional stability in
mm,
the shoulder joint. And that somehow initiated the idea
yes.
and justified for us the idea of doing high load strength training
Yes,
for this
because
population.
I read about the tissue stiffness. I have done some work in tissue stiffness myself, more looking at reaction time. But the elastography looks, so there was my fingers pulling apart the tendon. That is how. Can you tell us about those other studies that measured the tissue stiffness in the hypermobile?
Well, so elastography is we have tried to use it before on the shoulder to measure stiffness.
Mm-hmm.
It doesn't seem to be quite good on the shoulder, but if we look
Mm-hmm.
at some of the studies published, it is more on other joints. So
Yes.
what elastography basically tells us is that the tissue is somehow more soft,
Yes.
but it doesn't. I mean, the original way of measuring tendon stiffness or muscle stiffness would be to look at how the tendon or the muscle elongates
Yes.
while doing a muscular contraction. And that is something we are doing now on the knee joint because
Yes.
the patellar tendon is not round, the surface is not
Yes.
round as it is in the shoulder joint. So we are quite challenged in understanding the mechanistic aspects of the
Yes.
shoulder joint because it's unique and it's round and it's difficult to measure basically.
Yes, but you could see that in a patellar tendon because it's flat and easy to see the stress or the stretch on the tendon under load or when the muscle is contracting is what you're saying.
Yeah, and that seems to be quite longer. The stretch is more longer in hypermobile individuals, especially if we talk about like people with connective tissue disorders,
Yes.
such as
Yes.
Ehlers-Danlos syndrome and so on.
Yes.
So
And can
we are
you
trying now
explain
to,
to people?
sorry.
So I think you and I sort of have an understanding about load and how that might change those tissue mechanics, but what's the connection there for clinicians to understand? If you load the tissue, how do you think that might affect tendon stiffness? What's the rationale for people to understand that?
Well, we know that high load strength training can increase the cross-sectional area of the muscle.
Mm-hmm.
Can also help develop some of the cross links in the structures in the
Yes.
tendon and muscle
Yes.
structures. So, and we all kind of know that when we have done a high load strength training session, we feel more stiff the day after, don't we? Like we have sometimes we have DOMS,
Yes.
like muscle soreness, but
Yes.
we also feel a bit more stiff in our joints. And we know, for example, also from European handball that if you have played handball for 2 hours, you would basically be able to have a GERD, or
Yes.
you can meet
Yes.
the GERD definition because you're more stiff in your internal rotation. And
Yes.
so we know that exercise and high load exercise in particular can lead to some kind of stiffness. And what we tried to figure out was, is that then an adaptation that would persist after 4 months of exercise, basically?
It's so fascinating, isn't it, to think about how changes in response to load in the tendon then affects your joint mobility. Is fascinating to think about. But we shouldn't digress. Tell us more. This study, the study that you did, what did that entail? Can you tell us about the inclusion criteria for this study and what it is that you did? How
Sure. So it was, as you said, a randomized controlled trial. We included 100 patients, and all patients had a referral to physiotherapy. So they needed treatment for their condition. And on average, all patients had symptoms for 3 years. So that's a
okay.
lot.
Yes.
And it tells us that it's a patient group that don't necessarily meet physios or other healthcare practitioners who know what they need, what kind of treatment they need, basically.
Yes.
And we included males and females between the age of 18 and 65 years. And patients were included if they had generalized joint hypermobility. And we used the Behnam 9-point score
Yes.
with consensus-based cut points. But we also combined it with what we called historical generalized joint hypermobility by using the 5-part hypermobility questionnaire.
Yes. Tell us about that. Do you think, and so, because I was interested to see that, and because I've been measuring hypermobility, like looking for total range of glenohumeral rotation. So in supine, I would measure passive external rotation, passive internal rotation for a total range, thinking 90 external, 70 internal, and my population is pretty normal. In a hypermobile patient, 190, 200 is hypermobile. But you would advocate for the questionnaire. What are your thoughts here for clinicians?
Well, I would say the Behnam score, as you have already somehow told us, it doesn't include the shoulder joint.
Yes.
So using the Behnam score, you assume that if you have a positive Behnam score, then that would be 4 out of 9, at least 4 out of 9 for males, and 5 out of 9 for females. And but for females, there is a age cut point. So if you have females above the age of 50, you would have a positive score with 4 or more positive tests.
Yes.
But we assume that if you have a positive Behnam score, then your shoulder joint is probably also hypermobile. But then when we combine it with the 5-part hypermobility questionnaire, that has a question directly related to shoulder dislocation. So have you had previous shoulder knee dislocation? So that combination I find quite useful. And then you mention what is called the shoulder rotation hypermobility test, which is in literature described as a total rotation more than 180.
Okay.
And what is interesting or what I found interesting while doing the feasibility study in this population was that many of the patients who had symptoms in their shoulder, they couldn't move their shoulder at all. They couldn't move to 180. So by only using the shoulder rotation hypermobility test or the shoulder flexion hypermobility test, you might find a false negative result of that test. So that is a consideration
It's a
that you should do
problem,
as a
eh?
clinician.
Yes, and so I always measure then in the other side, but again, that's not to say that the other side is asymptomatic, because I think, oh, maybe there is guarding, in my clinical brain, maybe there is humeral head slipping, maybe that is what's impacting on your rotation. But you're saying, I mean, I could still continue to do that, but I guess particularly these other questions I ask patients often if I think they're double jointed. But there's another question about how you could amuse your friends by contorting your body into strange shapes. I don't typically ask my patients that, so that would be another way to find out, maybe.
Definitely, and we have also described what we call mechanical shoulder symptoms based on this RCT. And we found that 2 out of 3 of the patients had mechanical shoulder symptoms. And what is mechanical shoulder symptoms? That is subluxation, feeling that the shoulder is lax or loose. That is locking of the shoulder joint. So I always ask my patients about mechanical shoulder symptoms. So I ask them, for example, can you do something tricky or something that looks weird or something that makes some kind of a sound or a noise or clicking? Can you dislocate your shoulder? And I always say to the patient, so can you dislocate your shoulder? If they say yes, I always ask them, can you put it back in place?
Good.
That is a good question, isn't it? And then I always ask them, can I record it? Because I need it for educational purposes,
Okay.
So that is my standard question for all shoulder patients. Do you have mechanical symptoms? Can you dislocate or subluxate your shoulder? Can I see it? And that is so important to ask about, because we know that can somehow give us some ideas or a clue about the patient. Those who tend to have mechanical symptoms, they are more likely to be younger. They're more likely to have had symptoms for longer durations. And more patients with a previous dislocation report mechanical symptoms.
And you have defined the mechanical symptoms, like from what, if we can just recap that is the 3 things of, do you feel it loose? Do you feel it clicking? There was one more.
If you can subluxate your shoulder, if it subluxates during functional movements.
Okay. And the other thing that came from that discussion is you talked about a flexion instability. I don't know. What is that?
Or it's a flexion hypermobility test.
Okay.
Yeah, it's described as it's a test. It's part of it's a test battery for upper limb hypermobility.
Okay.
It's called, I believe it's called the upper limb hypermobility tool by Leslie Nicholson, Professor Leslie Nicholson, and it's well described, and it's basically where you put the patient in a supine position, and then you move their arm in a full flexion. And if the upper arm can rest easily on the massage table or physio table, then it's a positive test.
Okay.
But what is fascinating about the shoulder is that you can have hypermobility in certain directions. So you can have flexion hypermobility, but no rotational hypermobility. And you need to find out what directions they are hypermobile in or what directions they are unstable in, depending on what you're looking for.
what I'm looking for, and the patient demands, isn't it? I'm learning such a lot because I just typically have looked here, but now I will look into flexion and ask these other questions. As I was mentioning to you before we came online, was I now have a population, it seems, of pole dancers who need
Yeah.
to contort themselves under quite high load into all these positions. So I think that's really, really interesting. Come back to the study, because I feel like I could talk about you all. What did you do? What did you find? What is high load? How would you, this progressive high load that you talk of, what should clinicians take from what you did? Firstly, what did you do? What should clinicians do?
So the intervention that we called heavy is
Mm-hmm.
is a high load strengthening training program, but it's also exercises in full range, and
Yes.
it's exercises in what we call open kinetic chain.
Okay.
So it kind of challenges some of the understandings that we have had previously about how to address hypermobile joints. That you
Yes.
should do exercises that are not full range, do exercises that are not loaded, and if you
Yes.
can, do exercises that are not open kinetic chain, but instead work with the approximation of the joint where you try to somehow compress the
Yes.
joint surfaces
Yes.
together, right?
Yes.
So what we did is we had this intervention. We did a feasibility test to see if it was safe for the patients, or they could at least do it without getting adverse events or
Yes.
serious adverse events.
Yes.
And we started the exercise program with a 3-week adaptation period, and then moved on to a 12-week, 12 weeks of high load strength training.
Mm-hmm.
And for the last week before we did the testing, we had we decreased the load. We had some kind of a tapering just to allow for a better anabolic response prior to follow-up
Yes.
testing. And we used basically 5 exercises that target the scapula and rotator cuff muscles. And these included seated scaption, side-lying external rotation in neutral shoulder
Mm-hmm.
position, prone horizontal extension, prone external rotation, and prone scapular protraction. So the push-up plus phase of the
Okay.
protraction.
When you are supine, you are lying on your back for
Yeah,
the, yeah.
yeah.
Okay. Yeah.
So for the last one, for
Yes.
the
The
scapular
the
protraction,
scaption
you're lying. Yeah,
on your
you're
back.
lying on your back. Yeah.
Yes. Okay. Okay. And then they progressively loaded the weight that they would do for.
Yeah, so we basically built the program on a repetition maximum test. We did a 5 repetition maximum test
Yes.
at the first session, and after that we did the exercises after the initial 3 weeks. We did the exercises first for the first 6 weeks. We did 3 times 10 repetition maximum,
Yes.
and after that we did 4 sets of 8 repetition maximum.
Okay. Yeah.
So you could say it's for a patient population, it's heavy or it's high load,
Yes. Yes.
but it's not necessarily high load for an athletic population or something. Then I
No.
would go even lower to really do the training high load.
With less reps, you mean, and higher weight? Yes.
Exactly. Exactly.
Yes.
And
Okay.
that is, I mean, that is also a recommendation for the clinic, that this is an RCT. It's
Yes.
somehow you could say a proof of concept that you can do
Yes.
high load strength training for some individuals with
Yes.
hypermobility.
Yes.
But you can do, if the symptoms are not severe and if the patients respond
Yes.
positively to the exercises, I would go even higher with the load and even
Yes.
add some speed at some point.
Yes, yes, because I think the speed and the reaction, all those things that, influence in a functional, the way that you live functionally is also important in this population. How are clinicians going to know we talked about how to identify the population. How are they going to know that the patient is suitable necessarily for this type of program? I imagine some clinicians will be a little nervous around trying this with their patients. What sort of advice have you got for clinicians wanting to try some high-load training for their hypermobile patients? How to select them maybe, or who you think, or where to start? How to measure maybe their 5-rep max?
Well, that's a really good question, and also a really good perspective to have. So how do we identify those patients who would respond to high-load strengthening exercise? And the first thing I would say is what we found in the short term was that when we compare high-load strengthening exercise to what we called standard care, so low-load exercise in neutral to mid-range position, using basically no external load. We found that in the short term, it's better to do the high-load strengthening exercise. But in the long term, after 1 year, it doesn't necessarily have a better effect to do high-load exercise on shoulder function. We found in some sub-analyses, we found that it could be better doing high-load strengthening exercise for patient emotions about the shoulder. And you could say, okay, so practicing to be in this outer range gives you confidence. Gives you confidence that you can be in this position without getting injured or without getting a dislocation. So it might be that patients doing high-load exercise tend to have a better response in their emotions. But when we look at the results in long term, it didn't seem to be much better to do high-load strengthening.
You measured their confidence in the early stages. You measured to see their confidence, if their confidence changed.
Well, that is part of one of the questionnaires, the main outcome we had, the primary outcome we had, which is the WOSI questionnaire. And it has a subdomain
emotion,
that covers emotion and
And that's what you saw change in that first?
We saw a better change in long term. We saw a better change in the high-load training group.
In the long-term group to 12 months?
Like after 12 months, yeah.
And in the short term, you saw that change as well, or?
We did. So there was an improvement, and there was even a better improvement in the short term after the 4 months of doing high-load strength training. But as we know from studies where we do exercise versus exercise, when you stop doing the exercises, the function tends to meet in the long term. And just to add a brief comment about the shoulder rotation, shoulder hypermobility rotation test, we measured that in this RCT. And interestingly, we found that patients who did the high-load strengthening exercise, a larger proportion went from having a positive shoulder rotation hypermobility test to have a negative test after the high-load strength training than those who did the low-load exercise.
In that they moved to less than 180 degrees.
Yeah, so a larger proportion went from, the extreme range of motion was 243 degrees in the glenohumeral joint. I think you have seen some of the extremes as well.
I've seen some of them, but yes, it is a lot, isn't it?
It is a lot.
Yes. I've been thinking particularly lately, and we digress again, Behnam, but I've been thinking particularly about isometric strengthening in those outer ranges, because that's where I feel like that's where they're vulnerable, out past that. Is that something that's not necessarily something that you have done in the program, though, is it? It's not.
It's not something we've done in the program, but as a clinician, when I see patients, that is exactly what I would do. So I would start with some of the exercises, maybe some of the high-load exercises. So like prone external rotation, which is one of my favorite exercises. I would start with that without any external load. And then just do it for 2 minutes. So try to relearn or reactivate some of the muscles that control that movement.
Yes.
And then maybe after 6, 8 weeks of relearning that basic movement, you could add some extra or external
Extra
load.
load. And you pay attention that the scapula doesn't move when that happens. When I've done that, I've been really particular about scapula not moving and that it's glenohumeral movement only. You think I need to
Yeah.
do that or not
Well,
so fussy?
well, what I would focus on in that exercise is basically avoid extra shrugging. So if you
Yes.
shrug the scapula, that could
Yes.
be a sign of poor coordination of that movement. But it's okay
Yeah.
for scapula to retract.
Yes.
That would be good because that's some of the coordination that we would like to facilitate.
Yes. Okay. Okay. So the other thing that I saw in the paper, there was sort of increased muscle soreness and headaches in that high load group. Do you have any caution for clinicians around that? They should clinically, what should they do with it? They should tell their patients, look, this is what we expect, or you think now after playing with this for a while, there's something you would change, or
I definitely think it's a good conversation to have with the patient, just to prepare them about some of the minor adverse events they could expect by doing the high load strength training program. And well, for me, the muscle soreness is a sign of quality in the high load program, isn't it? So
for me
you've
too.
done your you've done your work, and it's a quality stamp. You could say that you
Yes.
actually have done your exercises correctly, but the headache could be a challenge. So
Yes.
what I would do is tell the patient that if you experience headache that is completely normal, it's transient, and what we could do is add some manual therapy or something that
Yes.
could maybe release that muscle
Yes.
tension that builds up that headache.
Yes, and when I read that, I was thinking in that population, the cervicogenic headaches, upper traps pulling on the base of the is that what you're at? What is that what you're thinking for them, or
That is basically what I see in clinic, and they
yeah,
get very sore scapular muscles. So the trapezius, the
yes,
semi spinalis, and so on. They are
yes,
quite
okay.
tense and sore.
Yes. Anyway, the implication for clinicians, what do you think the key messages is here for them to take home? What would you like clinicians to take away from the study that you've published?
Well, I would recommend everyone who have an interest in working with the shoulder to be aware of some of the things we've discussed today. So to be aware of how to identify patients or athletes with hypermobility. That could be localized hypermobility in the shoulder. It could also be generalized hypermobility. And use some of both the Baton tests and the 5-part questionnaire we have discussed, and some of the specific shoulder-related hypermobility measures to identify those patients. And it really starts in the subjective, that you should start asking about previous dislocations, mechanical shoulder symptoms. Ask them to show weird stuff, funny stuff, things that sound weird, and
Provided
don't
they
forget,
can relocate, those.
ask about dislocations if they can relocate it, and don't forget to record it if you get consent
Permission, yeah.
and permission, because that is for many of my patients with shoulder problems, when they discover, or I discover on their behalf, and explain them that they have instability or hypermobility, for many
Yes,
of them, it's the first time they hear it.
yes,
And that conversation is mind-blowing.
yeah, for
It's
them.
really, because it's a game changer in the way you address the symptoms. It's a game changer in the way you design the program,
Yeah,
and
yeah,
in the way you make sure that the quality in the exercises is there.
yeah,
And quality for this patient population is key. So you
yeah,
have to make sure that the quality is there. And what we defined in the project was that if you have, let's say, scapular instability, during movement. That scapular instability is acceptable, but
Yes.
if you add extra load,
Yes.
then you shouldn't have more scapular instability.
Okay, so you could differentiate.
Yeah, so
Yeah.
it's not about avoiding scapular instability because sometimes it's difficult to avoid it, but we
Yes.
don't want it to be more pronounced when you do
Yes.
the exercise.
Yes, okay. So you shouldn't like augment that or make that dyskinesis or faulty pattern worse.
Exactly,
Yeah.
exactly.
Yeah.
And especially the mechanical symptoms. I mean, patients
Yeah.
who have the locking or subluxation, I mean, I would do anything in the exercise program to avoid that. And that
Yes.
could be, it can be reduced range of motion for a short
Mm-hmm.
period of time.
Mm-hmm.
It could be reduced
Mm-hmm.
load. Sometimes, I mean, we did exercise 3 times a week.
Mm-hmm.
I would probably do, if it's really high load strengthening, I would probably do it once or twice a week
Yeah, okay.
because many of them, they don't recover fast enough to do 3 times.
Yeah, because this is a completely new experience for, I mean, a very untrained population, eh? Like if you think in a the difference between an athletic population and this population, this is very new to them.
Definitely. And
Yeah.
and I must say, based on this trial and my clinical experience, that in the RCT we had uh, athletes, young athletes, we had workers, we had
Yes.
males like builders
Yes.
who said, no, I'm not hypermobile at all. And
Yes.
then once you gave them time to relax and really gave them time to go to that end end range, then you
Yeah.
could see they were actually quite hypermobile, some of them.
Yeah.
So we need to be aware of this condition in all our shoulder patients. That would be my recommendation.
Yeah, I think that's a really good because they could have some underlying hypermobility even in that traumatic population,
Yeah,
you know? Yeah.
yeah.
What
And based on some of your previous studies, we know that
mm,
it's a risk factor for getting a shoulder
another
injury,
episode,
and
yeah.
it's a risk factor for getting dislocations, and
Yes,
it's also a risk factor for another episode, as you said.
yes,
So
yes.
it is a risk factor we should be aware of when we work with the shoulder.
Yeah, and I think I've learned such a lot about how I could quantify that better from our discussion today. What's next for you now? What are you working on now? Where is this sort of work going?
Well, currently I'm part of Anna Higo's PhD project in
Mhm.
the UK,
Yes,
and she's investigating external support in terms of dynamic orthosis as a
yes.
measure of stabilizing the hypermobile shoulder from outside
Okay,
that are comply with exercise-based treatments. And what
right.
I'm conducting at the time I'm conducting now at the university is that I'm doing high load strength training in hypermobile knees. So in patients with knee complaints and hypermobile knee joints and
Yes,
generalized joint hypermobility. But we have a larger focus on the mechanistic
yes,
adaptations and the tendon adaptations that we discussed earlier. And what is
yes,
exactly happening? What is the adaptations that can explain why high load strength training might work for this population?
yes. And you think we could extrapolate that to the shoulder? That's your sense that if you learn about the patellar tendon, we can think about that, how that might work too.
Definitely, because we have those indirect measures of improvement in tendon stiffness in the shoulder by using the hypermobility shoulder
Yes,
rotation hypermobility test. But it's difficult for now to do it in the shoulder. But we can learn so
yes,
much more from other joints,
yes.
and then apply that theory and that understanding to the shoulder as well.
Yes. Ah, it's wonderful, wonderful work, Behnam. Thanks for sharing that with us. That's
Thank you.
absolutely
Thank you so
fabulous.
much.
Ah, you're very welcome. I've learned such a lot from you. How do people follow your work? How do they know what you're up to and keep in touch with you? How could they learn more from you?
Well, I'm happy to say that all our research is open access and
Yeah,
freely available on
yeah,
PubMed, on the internet. So
right.
all the programs we put out there, the exercise programs, the leaflets we give to the patients have
Yes,
been translated to English and are
yeah,
available, freely available.
yes,
So
yes,
so people of yeah, please, people can feel free to find it, read it, and reach out if they have questions or they want to discuss collaboration opportunities. I'm very open to that as well.
Yes, so that's wonderful. If you could send me through those links, then I'll put them on the podcast, and then people can listen to our discussion and go straight to your papers. That would be wonderful.
I would do that.
Yes. Yes, cool. Thank you very much.
And thank you. It was a pleasure talking with you. So,
thank you. Thanks for joining us for today's podcast. I hope you've really enjoyed this content. You found some clinically useful tidbits, and some of the content has been thought-provoking. Don't forget you can follow me on my social media for some more up-to-date content. If you're looking for a shoulder brace, you can check that out via our shoulder braces on flawlessmotion.com. And if you wanted an online shoulder course, then I have a range of shoulder courses, through from an introductory shoulder course through to return to sport and a shoulder instability course. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session, so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well, take care.